Thank you, Francis. Happy to be here. I really enjoyed the last presentations and some of the presentations, yesterday they were fantastic. So building on that, you heard, about the standards work that the two organizations are currently performing and have been performing, both CIHI and Infoway. This is further building on to the current and the past collaboration, but looking more into the future, how the two organizations will continue to collaborate and advance the pan-Canadian digital health interoperability journey that we've been on for a while. Okay, so let's dive into this. Linda, in her last presentation, touched on some of the points around why do we really need a pan-Canadian digital interoperability. We do know that today we face some challenge with respect to the seamless flow of data from a patient perspective across the care continuum. So whether you look at a virtual visit encounter or an in-person encounter, the data doesn't necessarily flow 100% all the time to provide a comprehensive care to the patient. And to add to it, the providers and the patients do not have access to their comprehensive health record, in a digital manner all the time. So this does pose some challenge. And by the way, Canada is not the only country that actually goes through this. Number of other advanced countries, have been on this journey, and they are also still tackling with this problem. But I want to just touch upon, what does it mean, interoperability? Interoperability does sound like a technical term, but what really does it mean, from a patient, from a provider, and from a health system perspective? So from a patient perspective, as a patient, I would like to make sure that, I do get a proper transition of care when I go from one primary care setting to another setting, or a specialty or acute care. So that certainly means, that my health information should follow me, irrespective of the setting I am. And if that doesn't happen, it does pose some challenge, with respect to getting the timely and the proper treatment. The gap in the health information, the information not able to flow on a timely manner could actually cause some delay in terms of the care as a patient, that they expect to receive. And finally, the availability of the data. I'm sure, every person wants to access, their health data, and they want to be in control of their health data in a digital format. And then you could actually carry your health information with yourself. From a provider standpoint, it is a bigger issue because there are gaps in the health data and the information is not available in a standardized manner, in a comprehensive manner. The need to actually access and fetch the information from various places, various sources, does contribute to wastage of time, and clinician time is important, and then it contributes to the burnout. And the other part is when you look at the systems, that they use, the vendor systems, all of the workflows are not consistent. The way standards are implemented are not 100% consistent within the vendor system. So it does pose a challenge, for the clinicians, because there are the vendor market is fragmented, and they don't have a one consistent workflow or the data standards. From a health system perspective. Clearly, as we also saw during the pandemic, how important it is to get a timely information on as simple as hospital bed capacity, or getting an information on how many drug-related poisoning cases have been admitted to ED, so that proper public health surveillance measures could be taken place. So those are the things which as a health system we do need to have in place, and not having standardized data available to do that, it does pose a challenge to get that near real-time data. And finally, I think there was a great question, I think Huma asked in the last question, when would we be 100% digitized and interoperability will be done 100%? I can tell you interoperability has been around for last 20 years, and we have been on this journey for last 20 years. There is no end date to an interoperability. It's a continuous ongoing journey. We continue to get mature and better with passing time, and I think that's where we are. So I included some of the stats, that will help understand, the importance of both the availability of digitized information, but also the exchange of that information from a provider standpoint. So if you look on the left, this was the 2021 National Survey of Canadian Physicians, so wherein the results came out and said, please indicate which of the following aspects of clinical care communication, occurred electronically. So as you could see, we have really high maturity when it comes to access to the lab results and diagnostic results from a physician standpoint. But as you start to go down, hospital visits and then exchange of patient clinician summary, the e-referral request, it starts to go down. And those are the areas, where we need to work in. So the patient summary project or use case that Linda spoke about in her presentation would actually help us increase the maturity on some of those areas where the physicians could be able to exchange a comprehensive patient summary. And on the right side, you see a graph, we have, from a digitization perspective, we have seen a massive adoption. We're over 95% when it comes to EMR adoption amongst the physician. But from a clinical summary exchange perspective across or between the GPs, we're still low compared to some of the other countries. And this is one of the area where we all will have to work together. And standards, both the data and the technology standards do play an important role, but they are not the only factor. There are a number of other things, which you also saw in the last presentation. There are different layers of interoperability, but right on the top, you have organizational interoperability, which mostly deals, with the legislation, the legal, the trust framework, and those kind of things. Another graph that shows the informational continuity of care. So when this is again the survey from 2016 or 2015, yes, the percentage of encounters for which a specific type information was required when an information gap existed. So you could see the difference between connected and unconnected. So lab results or clinical referral notes, the power of connected data leads to less percentage of encounters, where the gap was there. Whereas, in an unconnected environment, you see there were more information gaps, which does result, in delay in timely care and physician burnout. So again, this is one of the different graphs to actually demonstrate that. And this is percentage of all encounters for which the cohort with a specific impact generated by an information gap. Again, you start to see the difference between the importance of the connected data, standardized data versus the unconnected data. And I think these are the things, which results in sometimes, duplicate appointments, duplicate or missed appointments, overbookings, duplicate lab results and everything. These are all the common outcomes of a connected versus an unconnected information available to the physicians. And this is the last graph, and we'll move to the next one. It is in the 2019, throwing a light on a little bit on the international comparison. As you could see on the left, when this was done in 2019, when we looked across the international counterparts and see, where we are with respect to physicians, be able to exchange the patient's clinical summary. Again, it is in a digital format, not 100%, sometimes in the standardized data format. Canada was at 22%, but it has since then moved up. So if the latest on the right shows, we're currently at 34%. Now this patient clinical summary, I have to remind you, this is not a 100% comprehensive clinical summary, which is what IPS, the International Patient Summary, dictates. It doesn't contain all those domains. It does include some of the health domains in it, and we're working right now, with several jurisdictions to see who have these on their roadmaps, to work with them to bring that IPS standard and that comprehensive record into the country. And Attila, in the next presentation right after this, will actually zoom into that work and how far we have come, working with our stakeholders. So looking forward, Infoway and CIHI, we have been working very closely with our FPT, stakeholders to see, okay, what should be the focus area, or what are the focus areas we need to actually really spend energy and focus on over the next few years to make sure that, some of the things that we saw in the past from an interoperability standpoint, that we do our part. And as mentioned, this is not the only thing. The data and the technology standards are not the only thing. There are a number of other things, that are also at play. But between the two organizations, what we have been doing and what we continue to do is across the three layers. How do we enable the health data in a common, standardized, and structured format? As you've seen from various presentations, a common, unified, aligned, validated data content standard, data exchange standard, and data terminology standards. How do we make sure that we not only actually announce and recommend, but also maintain and sustain them? The second is the secure exchange of data across all healthcare settings. Again, it is a pretty loaded focus, but then it is very important, for the vendors to understand, use the latest modern, the FHIR APIs, for the exchange of standards. Clearly define those standards, and how do we actually conform them and create a system, that actually helps them to clearly understand, what are the requirements, to conform to conformance of the standards. And then finally, patient access, access for the Canadians to their health data in a digital format. Now, this is again, yes, most of the jurisdictions have their provincial portal, but that portal may provide information to some of the content, but how do we define that comprehensive patient data and make it available in the repositories, that the patients can access, either through the provincial portal or through the other channels to access their information. So this is the focus area that the two organizations are focusing on and building the plans, working with healthcare and others to move forward. The two organizations, you heard about the standards work that the two organizations have been involved in, but I do want to also touch on some of the real life examples, that we have been working well for years. In addition to the content and the data exchange standard, there is a large program, a multi-year program, organ donation and transplant, which is again one of a fantastic interoperability case to bring disease donation management and a transplant living life donor management system, a common system with common interoperability and solution requirements to be implemented across all the organ donation centers across the country. This is where the two organizations have been successfully working over the last 3 years, defining that common set of requirements by collaborating all the jurisdictions and moving forward with a common procurement vendor. So that's a great example of interoperability work that the two organizations are involved in. The development of the EMR content standard and continuation of that. We talked about the EMR standard for the primary setting, but for acute care and long-term care, this is something that, over the coming years in future, the two organizations will continue to work together to define, announce, recommend, and then maintain and sustain them. And then finally, how do we actually work with the vendors to ensure that, it is applied and they conform to those standards. And finally, the projects around the PCLOCD and some of the other statistical surveys, that we jointly conduct, that actually help us inform our thinking and help work with our stakeholders to prioritize the areas of work that both organizations are actually engaged in. This is a simple depiction of how the two organizations are actually coming together and demonstrating their leadership in the health data and the standard area. So I'll start with the two outcomes. If you look at 8 and 9, if 8 and 9 are the two outcomes that we all have common alignment on, which is to provide access to the patient records, to patient, as well as ability for the providers to exchange data, and 9, making sure that the standardized data is available in a near real-time manner for health system use, research, decision making, etc. Then what are some of those inlets and support doors that we need to actually make it happen? Now, this is not the only thing that will solve the entire problem, but at least this shows our part that we're going to do to make sure. So on the top, we do need, and we're currently defining that stakeholder engagement framework, the broader governance structure, which I'll actually come to it in a bit, and then the privacy and security framework, which is part of the organizational interoperability top layer that actually defines how do we actually build some of the trust components into the data standards that allow the data exchange. So 1, 2, 3, and 4 really focus on jointly developing the data content standards, from a health data perspective. So if you look at, for example, US core data set of interoperability, they arrived at that, and all the stakeholders now leverage that to build their multiple use cases on top of that. So similar to that, how do we actually come up, with a with an information model, for primary care, an information model for acute care, and then long-term care and home health care, and then using that to inform or support the various projects or initiatives that the jurisdictions are actually implementing, so that they always draw onto a common baseline data set. So that's where, the 1, 2, and 3 are focusing on. 4 is clearly defining, the CIHI has been doing that for years successfully, is defining the indicators and the reporting KPIs whether it's the patient outcome performance or the physician experience or patient experience, number of indicators that actually help inform the healthcare data. 5 focuses on which Infoway has been doing in multiple roles, whether as a strategic investor or as a technology advisor, working very closely with our stakeholders to help understand, the requirements of the technology and the infrastructure, but also bringing some of the best practices to the table. For example, EHR blueprint that we wrote, with IPS implementation that we're working on. How do we bring some of the reference models and reference target architectures that US is implementing, as a reference to our stakeholders. 6 is a national procurement program. How do we inform all the vendors of the standardized requirements, whether it's around the solutions, whether it's around the interoperability requirements, whether it's around the standards or privacy and security requirements, because then they have a clear visibility on, okay, these are the requirements that we need to be qualified, to be procured for services by our stakeholders. So that is something that we started this year and we continue to work on it. We touched on the 2 areas, virtual visit and remote patient monitoring, and we'll be extending that broadly to other areas. And the final piece is vendor certification and conformance. We successfully did the EMR certification, ran the EMR certification program for a long time. But how do we actually pivot and expand that program and repurpose that program now to support the interoperability, which is similar to what ONC does in US, creating a nationwide framework, using partnering with several agencies to actually conform the vendors on various areas, because we alone cannot do the entire certification for the vendor community. So those are some things that we're working. Of course, the 2 organizations are working very closely together. As you can see, the work is intertwined, but also there is a great discipline between the 2 organizations to define clear roles and responsibilities amongst themselves. So that brings to the actual next part on how do we make it. It's like the art of possible. Yes, great things the 2 organizations are doing it, but how are the 2 organizations are actually working together to define this governance and make sure that there are clear roles and responsibilities. So working together, we have defined an approach on how we're going to work together, but we built some set of guiding principles between the 2 organizations. And then I would talk about the broader governance that we are currently in the process of socializing. Clearly, defining the goals and objectives on the outcome that we want to get to, it's a number 1 thing. And then building the measurable targets throughout the process is really important. What are the mechanisms and the checks and balance we're going to put in place to monitor the progress of our objectives, monitor the execution of our plans, and clear roles and responsibilities on who's doing what and when, right? So that's very important for building a joint governance model. And then the clear policies around the data making, decision making around the prioritization of the activities, because these type of roadmaps and work activities are usually dynamic in nature. So how do we actually make sure that as the new things come in, they don't disrupt the already planned things? So those are the things that we're. But then working very closely and listening to our stakeholders, which is the FPTs, to understand what are their priorities that would actually include into our roadmap, and we're not doing something in silo, but we're actually doing it for them. So those are some of the guiding principles that we put together. And why is governance needed? Governance is at the cornerstone for any type of initiatives, and especially something when you're trying to do something at a pan-Canadian level, it is absolutely required. And it doesn't have a start and an end date, as I mentioned before as well. And it is a journey that goes on. So we need to make sure that we implement the various stages of the governance of the life cycle of the engagements, which is directing, establishing the vision, establishing the goal, common alignment. Everybody stacks hand that yes, this is what we're doing. This is what will deliver from a primary healthcare standard perspective. Next would be acute care. So things like that. How do we actually have a shared vision and then prioritization? And then the next two steps is really around designing. So the actual doing the work in designing those standards. I think somebody asked a question question around how clinicians are involved. So that is usually during the design phase. How do we consult all the advisory groups, the clinicians, the policy advisory groups, and everything to design those standards. And then finally, it's the deployment. So deployment is usually with the stakeholders, with the provinces and territories based on their roadmaps, how they are implementing it. But we're there to actually support them, with the implementation, but also the adoption of those standards. And finally, sustaining. Yes, we have developed certain standards, we have developed certain specifications. How do we now sustain it? The two organizations. So we're building that governance and operational structure to make sure that, yes, depending on the needs, depending on the changes that come in, how do we actually sustain it so that we stay true to the baseline and not end up actually creating multiple versions across the country. So those are some of the things that need to be built into the governance structure. um, this is again in development right now, draft stage, and let me start with top, because governance, especially when you look at our health system, and and especially when you try to establish something at a pan-Canadian level, it could become complex. So how are we trying to actually pack it that it is effective and it could be run efficiently? So let me start with the top. And governance usually starts with the top, if any initiative has to be successful. Setting a strategic direction and gaining alignment on those direction is absolutely important. So if our goal is to actually advance digital health interoperability, to improve the exchange of information amongst provider, to improve the access to Canadians to their health data, it has to start at the top, and which is where I think our CDM table has done that. Now, if I go to the bottom, you see the logo Infoway and CIHI logo. That's where the two organizations are jointly currently working to design a governance on identifying, one, what are the various governances already in place, whether it's a pan-Canadian data strategy group or some of the other governances, understand that and see if we can actually leverage them or be part of that or plug into those, because we don't want to create duplicate tables. And then on the left, you see the various type of groups, the advisory groups, the privacy, the policy, the clinician, and the other advisory groups, the change group, the standards organization, which are usually embedded within the provincial teams. So how do we actually leverage them rather than actually creating net new? So that work is currently underway to do an assessment on what would that look like. And then in between, you see running a governance of this size and this complexity does require, significant strength, administrative effort, and manpower. So this is where you see the project office and the secretariat function that Infoway and CIHI are trying to actually design to run this type of governance. And then on the right, you see how would a steering structure look like? On the top, there is an interoperability and standard steering committee meeting, which is basically the approver of all the initiatives and the roadmaps and et cetera, et cetera. Then there is in the middle, the inverted triangle you see is the coordinating table, which is the coordinating table that will coordinate with all of the other advisory groups and the jurisdictions to make sure that the information is collected and everything. And then on the bottom, you see the various existing committees which are already there, which is the data information subcommittee, as well as the compliance committee. So as you could see, there is just a number of elements and wide variety of groups, that we need to factor in as we develop it. It is something that is still in a development stage. This was just a high level snapshot of, where we are thinking right now. So you heard from me the current governance and collaboration between Infoway and CIHI, and this is a more broader pan-Canadian governance that Infoway and CIHI will actually externally design and plan to establish as we move forward. And finally, as Huma asked, when are we going to be 100% digitized and 100% interoperable? I wish, today, but this is, if we do all of this together, yeah, we'll get to these outcomes, which we all have seen, heard, and said in various ways and manner. How do we improve the care through the secure exchange of patient data, enabling the availability of access to our citizens, in a digital format, providing ability of the data to be available in a near real time, so that better health system decisions could be taken, providing a digital health equity, through proper technology and infrastructure, and then giving the ability to our public health surveillance teams to actually make decisions, in the times, when it is needed. And then meeting our Canadians' expectation, around providing the data, and make sure that they are assured that yes, the data is traveling and transferred in successfully and in safer hands. So that would be the end of my presentation, and I would stop this and open up for Q&A.